This is Pod Populi.
Podcast for the people.
Hey everybody, welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing spinal cord and peripheral nerve stimulators. We have our very special guest with us, Dr. Yehuda Herschman. Thank you for coming on. Why don't you go ahead and tell our audience a little bit about yourself and how did you get to become a neurosurgeon?
Sure. Thank you, Deanna. I appreciate it. Happy to be here. Really excited. Originally from New York, and the first thing my encounter with neurosurgery, spine surgery, is actually my sister. So she ended up having adolescent scoliosis that got corrected, and all of a sudden that kind of sparks the interest. When I was in college, I got interested in things like Parkinson's disease, and the active research there had some ideas of things that I wanted to pursue, and that kind of drove me to get into the field of medicine, neurosurgery, and never let up on it. Things change and modulate over time, and we'll talk about neuromodulation today because that's what spinal cord stimulation and peripheral nerve stimulation is. But I've been happy that the journey brought me to where I am. I did my undergrad in New York City, my medical school in Chicago, and then my residency training in New Jersey with a fellowship in what's called functional stereotactic neurosurgery out in Jerusalem at Hadassah University Medical Center. And then came down here to Florida to practice, and very happy down here doing it.
And most people may not know, but neurosurgery has to be probably one of the longest roads you can take in any career, right?
Yeah.
Longer than most medical specialties.
It's a good 7 years of residency training, then fellowship. And most fellowships are 1 year. Sometimes they're 2. Some people will do more than one fellowship, just like other specialties. So it's a long haul to get to where you are just to start practicing.
And so a lot of people, there's misconceptions about what neurosurgeons do. A lot of people think it's just brain tumors, but there's a lot more to neurosurgery than that.
Oh, absolutely. We do a lot. So that was one of the things that drew me to neurosurgery or kept me going is the idea of just treating Parkinson's all day. We do that with the neurologists, and they're really the gatekeeper to that, mostly medical management before they require any type of, let's say, surgical or even now what's called exoblate type of procedure for these things. But brain tumors are always, interesting cases, whether they're pituitary tumors or metastases or gliomas, meningiomas, schwannomas. There's a wide variety of those. But the truth is most neurosurgeons around the country are doing spine surgery. They're, probably 60% of at least my practice, and some even more for a lot of other people. Their practice will be anywhere between 60 and 100% of just spine surgery, from deformity to just a regular discectomy for a herniated disc, or kyphoplasty for a fracture, stenosis for neurogenic claudication. It really runs the gamut. Peripheral nerve also can fall under neurosurgery. That's a field that's shared by neurosurgery, hand plastic, and orthopedic plastic. Orthopedic hand, for example. There's a lot of different overlap there. And then also in the pain world, we do overlap quite a bit. Spinal cord stimulation, peripheral nerve stimulation is also something that overlaps quite a bit. And then you have other subspecialties, pediatric neurosurgery that come along. There's neurotrauma. It's a huge breadth and depth. We're not even talking about neurovascular or aneurysm surgery, for example, which mostly now done endovascularly, but certain neurosurgical bypasses to augment blood flow or to trap aneurysms. I mean, these things can be quite complex. Most of these people do maybe 1 or 2 years of fellowship after 7 years of training. Skull-based surgery for terrible, meningiomas that are at the base of the skull and entwining with vascular structures, critical structures of nerves and the such. There's a lot that's there. It's very cool. It's beautiful anatomy that you can see, but it also can be very hair-raising at times.
I'm sure. And a lot of people probably have never even heard of many of those conditions.
Oh, I'm sure not.
Right.
I'm sure not. And because thankfully for most of them, they don't come across them and they don't have to deal with those things.
Right.
But for those that do, they usually, with the right help, guidance usually from their physicians, help to get them to the right people more often than not.
Can you explain, we've mentioned peripheral nerves, so can you explain to our audience, not everybody understands the anatomy, maybe just a general rundown of the nervous system?
Sure. So you have your brain. Your brain is like the computer, computes everything you hear, see, touch. It also commands you to do what you do, speech, language, motor, sensory, all those things, plus anything cognitive, emotional, thoughts, feelings, all those things. So from there you have those nerves go down through the brainstem into the spinal cord. The spinal cord controls all the sensory, motor, and coordination that goes to your limbs and toward your trunk as well. And in combination of those things, once the nerves leave the spinal cord itself, at that point it becomes technically a peripheral nerve. And each one is named. They all have their own names. So, for example, the most common one that people probably know is carpal tunnel, right? Carpal tunnel is actually the tunnel which the median nerve goes through, right? That's where it goes from your wrist into your hand. And patients classically will complain of numbness in their thumb, index, and middle finger. So they'll complain classically. They wake up in the middle of the night, have to shake out their hand. So if you're feeling that's more often than not carpal tunnel. Sometimes there can be also a lot of overlap between peripheral nerve pain, injury symptoms, and also from, let's say, your neck. You can have a herniated disc. You can have carpal tunnel at the same time, and there are ways to work that up in terms of which one is causing you a problem. EMG, for example, is very helpful with that.
And an EMG is what?
EMG is electromyography. So it's a test where have a neurologist basically put in a couple needles, not something too big, more like acupuncture-like needles, and then some electrodes. You stick them on, and they run electricity through. I know it sounds very exciting.
It sounds painful.
I haven't had it done myself, so
okay.
I can't tell you.
I'm pretty sure. Yeah.
And the idea is to see, like, are the currents through the nerve running appropriately? And if they're not, where is it that there's an issue in terms of how fast or slow is there latency and how it works? But that's one of the things that can help in terms of determining where's something coming from. Because like anything else in medicine, it's really about getting the correct diagnosis. If you get the correct diagnosis, more often than not, you can make the patient do well or happy. Even if it is a bad diagnosis, for example, at least they're informed of what's going on. They can make their decisions that they need to make. For example, let's say something terminal like a glioblastoma, like saying, yeah, this is probably what it is. With surgery, based on the data and evidence and literature, we have to know what the biomarkers of the tumor are. We need to know the genomics of the tumor, and that will help facilitate and know predictively how are you going to react to chemotherapy and radiation. And then on the other hand, sometimes you tell the patients and their family, hey, is this really worth it? You're like 83 years old. You're not going to be the same person after surgery type of thing.
Right. Yeah. And that's obviously not fun news to give.
No, but it's part of the job.
It's,
if you're taking call at a hospital, these things will come in. And that's just one of the things we're trained to deal with. These are one of the things that we all encounter professionally. And probably like anything else, some people better than others, and not from a technical standpoint, but in how they relate and convey that type of information.
Absolutely. And so today we're going to be talking about neurostimulators, and this is not anything new, right? Which I thought it was fairly new, and I learned the opposite.
Yeah, so neurostimulators have been around for a long time, dating back to the 1960s with two people came up with this idea called the pain gate theory, called Walls and Malczak. And the idea is very simple. So if let's say you're hammering something and you miss the nail and you hit your thumb, you're going to shake your hand out.
A lot.
And you don't even think about it, but you're shaking your hand. And in a sense, you have an overriding sensation where you're not thinking about the pain. And that's the idea behind it. Now, does that theory really hold up? I don't think anyone knows for sure, but that's kind of what we hold by, that the idea of the stimulation is that we modulate, we adjust the input-output going to the nerve, whatever is being bothered from the area of the spinal cord or at the level of the peripheral nerve, to going back to the brain. So you don't sense it as this is pain, this is dull now instead of sharp, this is a 2 out of 10 instead of a 10 out of 10 type of pain. And therefore, the idea with stimulation in general, any type of stimulators, and there's a huge gamut, we'll touch on it briefly. The idea is to improve functionality and quality of life. So we have stimulators for Parkinson's, epilepsy, and different types of stimulators for epilepsy, essential tremor, dystonia. There are special indications for OCD, for example, for brain stimulators. There's an ongoing NIH trial, to my knowledge, for refractory obesity, actually. So as we learn more about the brain, spinal cord, etc., and other disease processes, we're going to see more and more use of these things. Different types of epilepsies. There's vagal nerve stimulators also for epilepsy, but as actual original indication was for depression.
And if the audience out there doesn't know what epilepsy is, that's
for seizure disorders, yeah. So refractory depression is one. There are lots of different things that people are looking into now as well. And then you have the spinal cord stimulation level of things where You're putting these in for different types of pain syndromes more often than not. The most recent FDA approval and the expanding of these, there's actually diabetic peripheral neuropathy. And those patients do extraordinarily well. The burning in their feet goes away. And I'm finding that they're telling me after the procedure, after they're being programmed and everything, that, hey, I feel like my balance is better. I'm not finding that I'm getting my feet cut as much. The podiatrists seem to be happier. So overall, it's like a real benefit.
That's phenomenal.
It's a huge, huge plus for these patients. They oftentimes are, and I'm sure you've seen them too, they're on gabapentin and you're just constantly increasing their dose, and usually their kidneys are not that good, so you have to adjust. And then they're still complaining. We put this in, and more often than not, they're able to come off of the gabapentin in addition to having that pain control that they were not having.
Well, not only that, the side effects of gabapentin or Lyrica or any of the, other pain medications for nerves is just not good.
Yeah, I mean, everything has a side effect. Everything has a risk. So, medications have a risk. Drug reactions, side effects that interact with other drugs, or just a side effect itself. Just like surgery has their own risks as well. So you have to kind of weigh, is it worth it or not? And every patient is independent and they have their own issues. And you have to figure yes, no, or, you fall into some sort of gray area. So spinal cord stimulation has been a boon for that. That's a more recent advent, but more standard is post-laminectomy syndrome, chronic radiculopathy, low back pain. There are obviously off-label uses. There are constant studies going on, and, there's studies for pelvic pain, for example, refractory pelvic pain. I know I've used it for some patients who've ever had refractory postherpetic neuralgia for shingles.
Wow.
I know it's a bit of an off-label use, but it really works very, very, very nicely. Again, same idea. The lidocaine patches aren't working. The gabapentin's not working. Those patients find that they get really, really excellent relief. Phantom limb pain is another one where patients who've had an amputation due to an injury, or they're a vasculopath, for example, where they have bad blood flow, and because the artery to the leg was clogged, for example, and they couldn't save it, these patients get phantom limb pain and jerking, and this is a very good indication for spinal cord stimulation as well. Again, like anything else, nothing's ever 100%, and I counsel all the patients, say, listen, this is likely going to help you. We do a trial first. You kind of go home with the leads inside of you from a same-day procedure, and you say, okay, this is like test driving a car. Do you like the drive? Did it help you? And the insurance companies have a certain standard of 50% pain relief or greater, and they also require you to see a neuropsychologist to make sure that there are no other issues going on. But at the end of the day, 50% is arbitrary. What I've found, and I tell the patients, I said, listen, you'll know if this helps. If you're kind of on the fence, it's not for you. But if it helps you, you'll know with complete certainty how much it's helped. Because it's not going to just help with your pain. You'll find that other areas of your life are going to improve, other aspects. You're sleeping, perhaps you're walking, and then also sometimes your total affect. You find that you're more active, you can stand longer, all sorts of things. So that's part of, of spinal cord stimulation. And then same thing for peripheral nerve stimulation. More recently gotten very much into that. Very similar. These are short procedures to implant. It takes usually about 15, 20 minutes, and I don't even intubate patients for it anymore. I just use sedation as if you're having a colonoscopy.
Wow.
Does everybody get a trial stimulator first, or are there some people where you would just go to the permanent one?
That's an interesting question. So everyone gets a trial here in the United States. There's been some data published in Europe that shows that there's no difference in outcomes if you just implant for what you think is a good patient or not in terms of outcomes. So like any other European versus American divide, I don't know if that will hold enough weight here in the United States, especially with insurance companies. But right now the standards to do a trial, if you quote unquote fail the trial, meaning don't get enough pain relief, they will not pay for the implantation of the device.
And I'm sure there's a survey involved that you have the patients fill out maybe before and then after.
Correct. There is a documentation of there's a ODI score, I forgot the pronunciation. There's a disability type of information that, again, the insurance is required. It's a questionnaire of, where's your pain, how much does it limit you, and so on and so forth. And we keep track of those things as well. Mm-hmm. And typically, though, more often than not, patients find that they're, again, more functional. And on the flips, same thing with the peripheral nerve stimulators. This is really a great boon for those patients who don't have options left, particularly for shoulder, knee, and back pain. Again, this is a small procedure. Those patients who are a little bit older or have a lot of medical comorbidities, what you'll find is, or I've been finding, patient had a shoulder replacement, a total or reverse or something. X-rays look great. Patient complains, I still am having shoulder pain. They have good range of motion, but they're still having a lot of shoulder pain. Never went away. An orthopedic surgeon says, we got X-rays and CAT scans and everything looks perfect. There's nothing wrong. And the truth there is nothing wrong. There's a nerve that's irritated and bothered for whatever reason, and that's what's causing the pain. Nothing was done necessarily incorrectly. So I've been doing this for a number of the orthopedic surgeons here locally, and the results have been astounding. And advice on the other side of this is those patients who need that shoulder replacement, but they're either don't want it because they find the risk is too high for them, or the surgeon doesn't want to do it because they find that risk is not worth it at their age or their medical issues that maybe the graft won't take because they're 80 years old. This has been also fantastic. I've had patients come in where we do the trial and say, "No, okay, so how's your pain?" A week later, you know what, my pain is really well controlled, but I can actually sense and feel where the arthritis stops me, but I don't have pain when I do it. So I can feel the arthritis stopping me. I can't do this, but I get another few degrees of range of motion because the pain is no longer inhibiting them. And that's phenomenal. And the same thing goes for knees. And if you look at the literature from the orthopedic side, usually about 10% of patients who have knee replacement, shoulder replacement, all these types of joint replacements, 10% will have residual pain. And it's not a bad thing. If you think about it, 90% are doing great. Yeah. But for those 10%, that's a big deal for them still. And this is a really great way to take care of that and help these patients.
I mean, people don't understand, just in primary care, we talk a lot about activities of daily living, and are you able to perform laundry on your own or cook or clean? And if you are struggling to even be able to lift up that laundry basket or to load the washer, right? I mean, little things like that can really inhibit your lifestyle and therefore really impact your mood. And it's amazing that you can help in situations for people like that.
Absolutely. And not only that, it's, to your point, when I ask patients when they come into the office during their stimulator trial, so tell me, what else did it help you with? And, beforehand, I'll talk to them and counsel, like, what are you trying to get out of this? What activities do you want to be able to perform that you're struggling to? And I'll tell you, for example, the back pain one, the cluneal nerve stimulators, where we put the wire, that electrode over the iliac crest area to capture that nerve. Strangely enough, most patients say, I want to be able to stand by the counter and wash dishes or make myself food or cook. I enjoy cooking and I just can't stand for more than 10 minutes at a time. I just can't get it done. And then it's okay, when you're having the trial, do those things. See how much it helped. Did you get 20 minutes, 30 minutes, or an hour? Because if that's the case, on a trial, you're going to be in good shape.
Right. Yeah. Do you treat sciatica pain with this?
So if it's due to a herniated disc and you can make a good case that the MRI that you see where the herniated disc is in the same nerve distribution where the pain is, then no, you wouldn't do that. You'd probably do discectomy, or depending on what it is, maybe you would need a fusion if the bones are a variety of reasons. But if, for example, the MRI is completely negative, or there's nothing pushing on that nerve, or they've had prior surgery there and the sciatic pain has returned, then yeah, absolutely. This is a really good salvage for those patients. And they, again, can do quite well. And stimulators aren't just for neurosurgeons either, or pain physicians either. There are stimulators for bowel and bladder as well, usually done by the urologists, for patients with overactive bladder or retention or incontinence and things like that. So anything that has a nerve, in essence, that's firing, you can have a electrical impulse somehow interfere, modulate that signal going back to the spinal cord and to the brain to allow for an improved functionality of life. Can
they be used for neck pain or headaches or things that are higher up in the?
Absolutely. So neck pain is a little bit more challenging. Usually needs a little bit of a bigger workup than, let's say, back pain. You want to make sure that nothing's moving abnormally in the neck. And I have had a couple of patients like that. If they've had prior neck surgery, If they've done it from a posterior approach where they cut, let's say they'll do a laminectomy at the back of the neck, it makes it much more challenging because there's scar, and sometimes it's actually impossible to put it in. But there are other options. For example, patients with refractory headache, there's occipital nerve stimulation. Sometimes you can put some stimulators related to the supraorbital or infraorbital nerve that can help with headaches as well. I mean, there's a lot going on in that space. Unfortunately, sometimes we're limited due to insurance. Sometimes insurance will say, no, this is deemed experimental, even though there's actually quite good data, for example, for occipital nerve stimulation. There's a new trend to try deep brain stimulation again for refractory pain syndromes, especially chronic facial pain syndromes that are not necessarily trigeminal neuralgia, atypical facial pains. These things were tried years ago, and the data at the time showed that the efficacy lost over time, but they're coming back in vogue again. And people are trying it once more because now we understand things a little better. The technology's improved, and it's something that people can look into. There's a lot of different opportunities. There's also motor cortex stimulation. It's not really been adopted here necessarily in the United States, but it's definitely more popular in Europe, where you put a grid electrode on top of the motor cortex on the brain itself, or sometimes overlying the brain, to treat different types of pain also. There's a wide variety of things in terms of stimulation. Other options also sometimes for chronic types of pain is also an intrathecal pain pump, a pump that delivers medication, different types of medication directly to the spinal cord and the brain fluid, essentially. I personally don't like them very much. I find if it's for chronic pain symptoms, the patients just kind of have a higher and higher dose requirement, just like they would if they had oral medications. But for some patients, it can work quite well, especially if there are no other options.
Right.
So some of the questions that people ask about stimulators are, can you see them or can you feel them once you have one in?
So and how big are they?
Good question. Yes. So typically, once they're in, at least for me, when I put these in, there's usually two incisions. One incision in the middle of the back, let's say for a spinal cord stimulator, and one incision usually over the love handle area for where the battery goes. And the batteries they keep getting smaller and smaller. There are two types of batteries for most companies: a primary cell, which is non-rechargeable, and then there's a rechargeable. And most of the companies are saying the rechargeables can last 10 years, which is nice. Otherwise, you have to switch them out every time they kind of run out. The rechargeables are smaller. The primary cells are obviously bigger.
How long does the primary cell last?
Usually anywhere between 3 to 5 years. Okay. Depends on the patient, depends on how much juice you're using from the battery necessarily.
And then you have to have it removed and replaced.
Correct. And that's a fairly quick procedure. It takes about 15, 20 minutes, home the same day. Also just done with sedation more often than not. But it's a procedure nonetheless. And those procedures come with risk. The leads can move again, requiring a revision. They can obviously you're operating, can become infected. Those are things that always can happen. But the risks are quite low for that, and most patients do well. And they're happy to take that on. For example, they were doing well with the stimulator beforehand. They want that working again now.
Right.
So more often than not, they find it to be a worthwhile endeavor.
And then for the rechargeable kind, you said they're smaller. So do you have to come into the clinic for it to be charged? Is this something you do at home?
This is something they do at home. Usually there's a number of different companies that support this, and they will teach the patients and educate the patients on how to charge appropriately. Oftentimes they'll have their own programmer. So, different companies are different things. Sometimes it looks like an iPhone. Sometimes it looks like a Samsung. Sometimes it looks like a little stick, like a fire stick. Yeah, exactly. And where they can have multiple different programs, maybe for different types of activities, maybe for different types of pain or at night or what have you when they're more active. They can switch those different programs and adjust to stimulate, maybe one or two of the stimulation patterns. Not all of them, because as the technology has improved, the permutations, the amount of different types of stimulation patterns you have has increased exponentially, really exponentially. So it's been an exciting thing to see how that's grown, because in the past it used to be what we call tonic stimulation, where you just feel almost like a TENS unit at buzzing, and we would call that paresthesia coverage. That was about 15 years ago, where patients say, "Oh yeah, I feel the buzzing in my leg where it hurts." Yeah. Okay, you're good to go. That's what you get. And then now, in the last couple years, with the advent of high frequency, where instead of stimulating at a lower frequency of, let's say, 50 hertz, you're stimulating sometimes at a frequency of 10,000 hertz. you don't feel the stimulation as a patient. You get what's called paresthesia-free coverage. So you don't feel the buzzing, but you'll feel the coverage of the pain, meaning the pain will abate, the pain will get better to a certain extent. And this is great for patients because some patients could not stand the paresthesia. They found it more annoying than the pain.
Right.
So at some point, people would have a trade-off, this and that. Is it worth it having the paresthesias, but the pain is better or not? The other thing that improved is with the technology is that they're now MRI compatible, most of them, or rather MRI conditional. So
that was another question I was going to ask.
Yeah, in the past, it would be really painful. You have someone who had a stimulator put in, and I still see some of these patients periodically where they have a stimulator put in, it's not MRI compatible, they require an MRI, and you got to take it out if they really need that MRI.
Yeah.
Obviously, that's a surgery, and sometimes it's smooth, other times it causes other issues, but thankfully now most of them are MRI conditional, kind of similar to what you're seeing in the cardiac world with pacemakers too. It's a similar kind of concept.
And even like in ortho, they use titanium, or those are MRI compatible. Like a lot of things are becoming that.
A lot of them are MRI compatible. It's not really so much the material itself that it's titanium and other elements in there. It's more about what happens to it,
the pole,
when you're in the MRI scanner. So the MRI, because it's titanium, the MRI is not going to pull it, but what it can do is it can heat it up. It can generate heat. Mm-hmm. And it's not usually so much the electrodes that are the issue, the wires, but it's really more the battery. And that's part of what the issue is. And there's always, every time they want to improve these things, they have to go through FDA testing. So the FDA keeps a close eye on those types of things. And anytime there's an issue, obviously they can, like any other medication or device, there can be a recall, for example.
If someone has a pacemaker or a implanted defibrillator, can they get a stimulator?
Absolutely. I have plenty of patients who do. Sometimes a little more tricky. Oftentimes those patients can be on anticoagulation, so they have to come off of the anticoagulation during the trial period and also during the stimulator being placed. But once everything's done, usually I let them start back 2 weeks later. And the more difficult issue for pacemakers and defibrillators is, let's say, a vagal nerve stimulator, where we only put the vagal nerve stimulator on the left-hand side of the neck. So typically the battery is also on the left. You'd have to figure something else out. And this is eminently doable. There's no question. Same thing, when you do deep brain stimulation, it used to be one battery on each side for each set of leads. Now a lot of us have moved to just putting one battery for both leads. And, oftentimes people will consider let's put it on the right side in case the patient needs a pacemaker in the future. But sometimes that happens and it gets in the way and you got to figure something out.
And you had said that the algorithms keep changing, that they keep coming up with better ones. Can the firmware on these things be upgraded without having to remove it?
Often, yes. That's really been very nice. Often they can have certain upgrades and can do it even remotely for some of the companies. Others, not so much. Each one's a little bit different. But yeah, the algorithm and the programming capabilities have grown so much in terms of the energy it can deliver, how it delivers energy, how deep it can penetrate into the spinal cord energy-wise, what we call things that we adjust frequency pulse with and so on, different patterns of stimulation bursts, and it's really been very interesting to see this. And different types of pathologies, different types of medical issues that patients may encounter may benefit from different types of stimulation, meaning not everyone's going to be good with high frequencies. Some patients may need something that's more like burst, or maybe even old-style tonic, where they just feel the paresthesia coverage. And that might be better for them. And each patient's different. Mm-hmm. And I'll tell patients, don't give up yet. There's so many things to try before you jump ship and say, this isn't really working. But the truth is most patients, 80% of patients kind of fall into one type of category where the high frequency typically often does well.
Now, where you put the, I guess, I don't know what you called it, not the receptor, but
the electrodes.
The electrodes. Yeah. Like that is in a different location depending on the person's point of
Correct.
pain, right?
Correct. Yeah. So the electrodes for a spinal cord stimulator go into the spine itself, not in the spinal cord, but in that space called the epidural space. So that's the space that goes between the bone and the covering of the spinal cord called the dura. So, for women, if they've ever, delivered a baby and had either a C-section or a vaginal birth, or they had an epidural catheter, It's the same type of idea. It goes into that same space, but just not in the lower back, but usually higher up. More often than not, for issues of the legs, feet, and back, we put it in the thoracic spine, anywhere between T6 and typically like T10. Other studies are looking, for example, in pelvic pain to be lower down. In the neck, sometimes we try to get up, if you have, let's say, refractory neck pain, you try to get all the way up to C1-2 more often than not. If it's, let's say, phantom limb pain, depending on where it is in the neck, trying to get maybe C5, 6, 7 or C4, 5, 6, 7, depends on where it is.
So you can have multiple.
Yeah, so these electrodes often have 8 separate contacts on each. Wow. And there are different types of electrodes. There's what's called the percutaneous, or these little noodle-like electrodes, or a paddle. And they're a little bit different in the procedure. The first type is a little bit less morbid. There's less dissection. It's using a needle like you use an epidural. Mm-hmm. And I tell patients it's similar to an injection in the back, but instead of putting medication, we're just threading a wire through there and leaving it. The second type is called the paddle electrode, and that requires a little bit of a laminectomy where you drill off the back of the bone and then slide the paddle up into that space. It's definitely more invasive, but some people require it. Sometimes there are patients that definitely would do better with that. What I personally like about the what's called the percutaneous electrodes, those kind of noodle-like electrodes or the thin ones, is it gives you can configure it a little bit differently. You can stagger them in a way so that instead of only spanning 2 vertebral segments, you can do 3 or 4 potentially and capture if the patient has more than one type of pain. There's one patient in particular that stands out in mind with this. This guy had prior spine surgery in his back, was having leg pain from that, but he was also having really bad burning pain and is free from diabetes. So essentially, we were able to take care of both things by staggering the electrodes kind of like this, where one is higher, the other one is overlapping at the bottom, and you get to cover the whole area that would treat both of those issues.
That's awesome. And okay, so are they wireless then? Because you put in the electrodes and then you put in the battery pack, or do you have to feed a wire through then?
You're a little bit like an electrician.
Curious.
You gotta tunnel those wires from one incision to the other.
Okay, wow.
But yeah, as you're asking earlier, do people see it? Not necessarily. Nothing's sticking out.
Right.
More often than not, the only thing people may see is the bulge of, let's say, the battery. And that's also a little bit dependent on the patient's body habitus. Are they big? Are they a tiny little woman? Are they a heavy set guy?
Right.
So obviously, the people who are more heavy set, they can hide it better. People who are thinner, that may show.
Right. Okay.
Are there any restrictions on the person's activity after?
So typically, I'll restrict them for almost 2 months. The idea is that if the leads are in place and it's helping them, I want them to scar in place. Once they hit 2 months, I get x-rays to say, oh, this is exactly where we put them. Nothing has moved. Nothing has changed. I kind of ease the restrictions. Say, kind of ease yourself back into the normal routine of things that you want to do. And that's been working.
Wow. And you said earlier that sometimes it's covered by insurance, sometimes it's not. So what's your, success rate with insurance?
Yeah, so more often than not, it is accepted. As long as you're following the guidelines, as long as you're following those rules, so to speak, and the indications, then the insurance more often than not will accept it. Sometimes some insurance companies will fight, saying, oh, you didn't do enough of this and that other conservative therapy beforehand. And the reality is more often than not, that's not going to help, and we all know it, but they just kind of push you through this whole set of hoops. Obviously, on their side, they don't always want to pay for this because it's an expensive device. I mean, this can be $40,000 that the insurance is going to cough up. But on the other hand, if it decreases their visits, let's say to the emergency room, pain doctor's visits, opioid prescriptions, and so on and so forth, and it lasts 10, 15 years or more, then more often than not, then perhaps there's a cost savings there at the end of the day. But it is an expensive device. On the flip side also, if it's for a younger patient who, let's say, has been in an accident or whatever, can't work, getting them back to work is a huge deal.
Absolutely.
It's a huge deal. Get them back in, but not just financially, but societally. There's a lot of mental toll by just sitting at home and not doing anything. I mean, it helps in more ways than one.
Well, I think this has been very informative, and I've learned a lot about these spinal cord stimulators and peripheral nerve stimulators. Thank you so much. How can our audience find you?
So, they can Google us. I'm here in Palm Beach County. They can Google us at Palm Beach Neurosurgery, and our website is pbneurosurgery.com. They can always call. Our phone number for the office is 561-433-4444. And we have 2 offices, one in Jupiter and one Lake Worth, but we see people from all over. They come. And, it's a matter of there are plenty of people doing it. So it's a fairly ubiquitous procedure. But if they want to come see me, I'm happy to see them. And we can help arrange those things too.
Awesome. Thank you, Dr.
Thank
Herschman.
you.
Yeah, no, thank you for having me.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.